Can I just record the?
Karina, what about my video?
Hi. Okay.
All right.
Your
Settle down.
was yours.
Great, thank you. So we've got this one. We had this one. It doesn't have the software Bivent. It's a little bit older.
The dinosaur.
This one does. So we're in Bivent right now. Let me change the alarms really quick before this drives me insane. Who set this?
That's how you do it. Wrong thing.
Always adjust your patient, not the alarms. But this is just out of whack right now because we're using this for testing. Okay, great. All right, Bivent. So, as we're talking about, we have P high, which is the pressure which is in the lungs for the majority of the time. This you'll set at your P mean or 5 above your plateau on the previous settings. So if your P mean was 25, you would set it to 25. If your plateau is 25, you'd set this to 30. Nice. We have basic arithmetic down. I approve. PEEP is set to 0. When?
Always.
All the time. All right. O2, obviously, they're probably going to be at least 60. If you're using this advanced ventilator strategy, they might be at more, they might be at 100. Depends on what your patient's coming from. T inspiratory rise, also known as ramp, also known as T inspiratory rise. That was a trick question. That's mostly for patient comfort. So that's how quickly they're going to get their breaths. T high is how you control your rate, right?
Hi.
So T high, that's the inspiratory time. So if I turn this down, you can see the I to E changing. Now it's 5.1 to 1, rather. And it's giving me a low PEEP right now because I have my PEEP set to 0, right? In a patient where you'd actually be using this, they'd have some intrinsic PEEP. And if you take a look at the lungs, you'll actually see, silence yourself. You'll actually see it doing what we call a sigh breath, which is letting all the air out now, and then inflating it again and holding it. It's pretty cool. Super backwards, but it works. You can also see that we have supported breaths on here. So that tells you that they planned for spontaneous breaths from the patient. So you can pressure support to P high. You can set that to just like your normal pressure support, and pressure support above PEEP. You're not really going to be touching that because your PEEP is going to be 0. Notice how I've said PEEP is going to be 0 a lot of times. It's almost like that's going to be on the exam. It will be on the
Boards?
exam. Boards maybe, definitely this exam.
So PS above P high, so it's the pressure support above the pressure.
Yeah, so PS above P high, that's for
Above
spontaneous breaths. Yeah, but the thing is, that's not going to have any spontaneous breaths, and I'm not going to be able to trigger any because normally I would just like pry open. Don't punch it. Don't punch it. So earlier, let me turn this down. If we turn down the time at inspiration, or if we turn down the T high, what will happen to our respiratory rate? Why would it decrease?
Wait, no, hold on.
No, it's gonna be because they're going faster.
Exactly. It will increase because you're spending less time there. So you won't be using as much time at inspiration. You'll be able to cycle more frequently, right? The respirations for this mode will be relatively low because you're focusing on the recruitment. I'm just going to fix the PEEP low here. Accept. And we go back to Bivent. So weaning is kind of the same principle. You want to get them back down to where they were previously if you had increased on their settings. And ideally, you want their underlying issues to be resolving, aka you see on their chest x-ray, it's improving, lab values are improving, patient overall is improving. And then you'll know, okay, maybe we can try them back on normal mode. And then if they can't tolerate it, put them back, just as we do with everything. We always try to see how far we can go before pulling ourselves back. The cool thing about this is that you don't have to change machines for Bivent. If you're switching them back and forth between this and the HFOV, it's going to be very time consuming one, and it's going to be very hard on the patient because you're disconnecting them, reconnecting them probably twice. If you disconnected them to put them on that, or I'm sorry, if you disconnect them to put them on a normal vent and then they didn't tolerate it, then you have to disconnect them again and then put them back on the HFOV, which you're going to lose a lot of PEEP, you're going to lose a lot of lung recruitment unless you clamp off the ET tube, right? So that's a very cautious thing to do. It's a little bit easier on the servo. Other vents have this too. The servo is just like the really accessible one that we have, and it's pretty easy to use because it explains everything. Here, it won't let you go below 0.2 for the inspiratory time. I've taken it down. Let's see. I'll take it down to 3.0. So it'll calculate the breaths per minute up here in the corner on this particular vent. Not all the time you'll see that, but it's very useful. So you don't have to wait and see, all right, what's my respiratory rate going to be? Or you don't have to do math, which I love not doing math. It's my favorite pastime, not doing math. So it'll bring the respiratory rate up to 15, and it gives you your IDE here. Right now it's 3.0 to 1. And if I change my time at PEEP, or T-PEEP, or T-low, you'll also hear it. Those are all the same thing, and this will also adjust the IDE. Makes sense? Mm-hmm. Get your hands on with this. It's pretty easy to use, and if you have any questions about it, let us know. So we've gone over, yes?
Spontaneous. So when they make a spontaneous breath, is it gonna be like that or a real breath?
So when they make a spontaneous breath, so it's going to exhale here in a second. It'll add pressure support to that inhalation.
Okay, so it's gonna like,
Yeah, and then it'll hold.
okay.
So it'll be like hold, and then hold, and then exhale.
Okay.
All right, good question, because that one, it works a little bit differently than in normal modes. Any other questions about Bivent right now? Who wants to get hands-on with Bivent? Who wants to get hands-on with HFOV?
I wanna get up at one.
All right, get your gloves on.
Where is cycle off?
Yeah.
What is that?
So at 30%, it'll, hold on.
Does it really affect anything?
It should. So one way to check is to make it the most extreme, obviously when you're not on a patient, and then see what changes.